This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of personal care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details. Before we get started with the episode, just a quick word from Great Western Air Ambulance Charity. Great Western Air Ambulance Charity Clinical Symposium is happening on Friday the 16th of October 2026, and that's going to be at Ashton Gate Stadium in Bristol. And this year's focus is going to be on innovation. So the day brings together GWAAC's critical care team and a range of guest speakers, all sharing insights and approaches that are designed to be immediately useful. So things really that you can take away, reflect on and start putting into practice straight away. So it's not about a theory for the sake of it, it's really about real world application into principal and critical care settings. So there are only around 120 tickets available. These tickets go on sale in June, but you can already pre-register your interest to be the first to hear when they're released, along with updates on future events. Just head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today, I'm joined by Callum Sutton, a critical care paramedic for Great Western Air Ambulance Charity, to talk about the true value of HEMS and where it can really make a difference on scene. So it's true to say that few decisions are more critical than knowing when to bring an advanced critical care team to the scene. And in this episode, what we're going to discuss really is about that early call for help, understanding which patients will benefit from a critical care team, and also understanding the physiology and indeed the interventions and ceiling of care that can change the trajectory of the patient outcome. Also, what happens before the helicopter lands or indeed the critical care comes to the scene. So optimizing access, monitoring, anticipating procedures like emergency anaesthesia, but also small actions on the ground and how that translates to critical time saved. So really we're going to discuss really the foresight, the teamwork, the marginal gains and how the right moments can mean everything within critical care. Welcome to the podcast, Callum.
Thanks for having me. I'm looking forward to this chat.
It's great to have you with us again. So I guess just to start the conversation off, could I get you to really maybe just define for us, from your perspective, so maybe the key clinical and or situational triggers that should make a crew on scene think early, really, this would merit a critical care team?
I think really any kind of patient that you walk into and immediately kind of think, "Whoa, this patient's pretty sick here." I'd start having that thought in the back of your mind, because I think that aim of critical care in this day and age when we come to scene isn't really to take over the care of that patient or anything. It's more just to blend in and add that kind of extra layer to what is already being provided. There's obviously some kind of big obvious key patient groups that we're really interested in. There's obviously major trauma patients who have got polytrauma and bleeding or the traumatic brain injuries and that kind of thing. Your kind of ROS patients and your specialist cardiac arrest, like your pediatrics and your VF patients and Brownings, hypothermias, all those kind of things. Your acute behavioral disturbance type patients and your kind of drug overdoses, especially those kind of polypharmacy overdoses or tricyclic antidepressants, serotonin syndromes, those kind of things are the kind of big patient cohorts, I guess. But we can also kind of help out with lots of other patients, kind of complicated maternity patients, those septic patients that are a difficult extrication, or hypotensive, or kind of on the cusp of respiratory failure and all of that kind of thing as well. So I guess, plenty of patient cohorts, but any time that you kind of think you're maxing out the therapy that you can offer, or that the patient is really unwell, um, always worth just having a conversation and seeing if there's somebody around who can come and supplement the care that you're already providing, I think.
Yeah, to your point, Callum, I think it's really important to share decisions. If like you said, there's an indication that this patient is critical care, just even calling up the desk and just running the symptomatology or the case presentation by someone like yourself, just to say, look, this is what I've got. I'm not sure it actually reflects what you're seeing on the screen, and just to give you that extra valence, that extra detail to help that shared decision making. Really, absolutely. We were talking offline, and this is quite complex in a way that, articulating maybe those patients which didn't get a critical care response, maybe through audit or otherwise, or because there's maybe not an absence of out of hours service, but could I get you to really speak to really some of the knowledge gaps where you can maybe think, oh gosh, actually, a critical care team would have added value if it would have been dispatched to this patient. Could I get you to kind of speak to that? Maybe that knowledge gap, or indeed maybe some of those case presentations you've been aware of where crews should think actually there could really be added value from a critical care team here.
I think a big one that is often missed is those overdose patients, So you kind of, a lot of the overdoses that are seen in the UK are related to opiates and those kind of things. And an ambulance crew can absolutely manage those patients to a really high standard with, airway management, oxygenation, and naloxone as required. But some of those kind of more complicated overdoses or those polypharmacy overdoses, there is a lot that can actually be provided for those patients. So yeah, your kind of tricyclic antidepressants, calcium channel blockers, beta blockers, especially things like propranolol, and that kind of thing. Patients who have kind of psychostimulants and that kind of thing ending up in serotonin syndrome. A lot of those patients will need kind of advanced airway management and pre-hospital anesthetic, but as well as that, we'll kind of carry a number of pharmacological options that are available to us to kind of manage the cardiotoxic effects of some of those drug overdoses, um, as well as vasopressor therapy for the kind of hypotensive patients and that kind of thing. So I think overdoses are one where I've had a number of patients where kind of in the debrief it's come up that people don't realize that we can kind of offer that care. And I think often kind of things people think about is cardiac arrest and major trauma. And they are obviously big patient cohorts for us, but there is a big group in the middle there that aren't in those situations where we can help with. Um, other things like life-threatening asthma is a big one as well. We've got a lot that we can add pharmacologically to those patients. We will try and avoid anesthetizing them if we can at all costs, but we can intervene earlier with things like magnesium and that kind of thing. But Thea is an option there if it's required as well for those patients. Um, Eclamptic patients or kind of complicated deliveries and those kind of things, neonatal pediatric resuscitation, um, and then you know septic patients and arrhythmia patients as well. So again, sepsis patients with um, non-invasive ventilation if required, or respiratory failure patients, vasopressors, and then managing arrhythmias as well. So if you've got that patient who's in kind of pulsed VT or something like that, but they're starting to head downhill, you've got a long transport time to hospital, then again, medications and cardioversion, pacing for the bradycardic patients. And also, I guess, just thinking about the journey into the hospital, we can kind of smooth over that journey for you, or activate some in hospital um, pathways as well, depending on where you are in the country in terms of kind of ECMO pathways and that kind of thing that might just smooth that patient journey over for you.
Yeah, indeed, indeed. And maybe what I'll do, and we can come to this, is really just to get listeners, or indeed help listeners understand the actual breadth and depth of the coverage of the area that you cover. It's a huge area, and indeed the resources you utilize to cover that area. We'll talk about the spectrum because there is a spectrum of these high yield patients with early dispatch, and then we'll talk about over dispatch. But could maybe just for a sense of for listeners, just the actual enormity of the geographical area that you cover.
Worries. So yeah, I mean for ourselves, it's a large area, so I think we cover about 2.5 to 3 million patients across kind of the southwest patch, which kind of for us extends from Gloucestershire down to kind of Somerset and across towards Bath to border Wiltshire and through Bristol and across into the Forest of Dean and all those places. So for us, that's our kind of area, which yeah, I mean we're quite lucky. We've got some beachside areas. We've got some big urban populations and also some rural areas. So it is another reason why it's key talking talking to the desk early because they can help you with that logistics. And we know we're lucky enough we can call across the southwest. We've got a number of other teams, and so we can mutual aid across into each other's areas. And so if you call early, we can make those decisions on. Um, another team from a different area or whether it is worth you just moving and that kind of thing. So joint decision making and involving a senior decision maker is something that I think is really key. I think as a profession, as paramedicine, we've kind of evolved, haven't we? I certainly remember when I was kind of going through uni and a student that it was kind of if you didn't know every word of your guideline and you needed to talk to someone to make a decision, you were kind of seen as a bad paramedic. Whereas that's clearly not true. And every day, senior clinicians, the consultants that we work with, even when they're in hospital, we'll cross check things with other consultants and stuff. So the more shared decision making, the better it makes for you. And even if we can't get somebody to you from the desk and the advice line, we can help you through things. So we've had pediatric cardiac arrest, where before the team has made it to assist, we've been on speakerphone and able to provide, drug values and dosages and just help the crews on scene through remote support as well.
Yeah, I think that's powerful, and it's absolutely necessary in those moments. Let's look at those high yield patients, Callum. The ones with really benefit from early dispatch. Could you get to maybe speak to those presentations which really consistently change outcomes from that early dispatch?
The evidence has kind of shown us, hasn't it, is kind of traumatic brain injury, and that patient cohort is probably a big one. So anyone who's sustained a traumatic brain injury and is agitated or has a reduced level of consciousness is someone that we want to be involved with. Equally, that kind of polytrauma patient is another one. And there's been a big paper released recently within the UK environment, which used AI to kind of look at outcomes for patients who receive pre-hospital anaesthetic and that kind of thing, and showed an improved outcome for some of those patients. So um, we definitely want to be getting to those patients. Penetrating trauma, is another one where we're often called along to, and we do want to be part of those. What we don't want to do is kind of hold scenes up for our arrival. So we definitely want people to kind of move and we've chatted before about Stab 5 and looking to RV with crews and that kind of thing. Um, and then I think kind of moving outside of the trauma environment, that kind of cardiac arrest patient. Now, great standard of ALS being provided by paramedics and ambulance crews on the road these days. And so not every cardiac arrest is somebody who will benefit from a critical care dispatch. But some of those kind of special circumstance cardiac arrests, the ventricular fibrillations, the witnessed arrest, the young cohort, the pediatric cohort, hypothermia, those kind of patients where we can do activate pathways and can kind of come in with a number of different options to manage those patients, which is kind of emerging now when you look at things like arterial access and dual sequential defibrillation and things like that, just to add on that extra layer on top of what ALS is providing. Um, so I think they're probably the kind of big cohort of patients that we want to be at early, but the ones mentioned previously as well are always ones to have in the back of your mind. And I think again, it's all about calling early because it's a lot harder to kind of catch up with a situation if you're there late in the game. And we know that that's difficult already given response times in the modern world.
Yeah, absolutely, absolutely. So let's look at the converse of that situation, Callum, and just maybe around crews that over request or could over request, or indeed there's this sense of over triage. Could I get you to speak to some common scenarios really that you see play out with the potential? It's always a fine balancing act, isn't it? And I think you want to overly encourage people to call rather than not call. But to your point about contacting the desk rather than, just to get that shared decision making, to just to increase the accuracy of dispatch and the added value. But could I get you to speak to that sense of over dispatch and whether you see it play out in reality?
It's always something to kind of have in the back of our minds, isn't it? Just because obviously critical care resources are a finite resource, and you want to be available for the patients where you are going to make that significant difference. But I would, yeah, firstly, always encourage people to call and chat and discuss that any patient they have. But I guess just kind of reinforce to paramedics that are out there that they're doing a fantastic job. And there is a lot of patients who, they may not see these kind of patients often, but actually their treatments that they have in their armory are beneficial to the patient and will, in most cases, kind of sort that patient out. I think a big one is kind of patients having seizures. So seizure patients, we can add extra pharmacology into and pre-hospital anesthetic if it gets to that stage, but that is so rarely required for patients having seizures. And actually, most patients will self-resolve, and if not, a dose or two of benzodiazepines will do that job for you. So I think that's kind of a big one, just to have confidence in your ability to manage the patient and know that if they're oxygenating well and you're giving kind of benzos, that is what that patient needs. And actually, if the patient doesn't respond to those, then absolutely we can have a discussion about coming along. But I think you'll find, and most of the time when we have discussions with crews about seizures and stuff, actually we find that by the time we've had that discussion and done that initial management, patient's actually very well managed and sorted from that. I think another one is kind of enhanced analgesia, and we're always happy to come along and provide procedural sedation to realign a limb or reduce a fracture dislocation and that kind of thing. Um, but I just would kind of encourage people again to be confident with their analgesic options. And sometimes we get some analgesia requests where the patient hasn't had a lot of analgesia, I suppose, and just be confident that pain is a big stimulant. And if you've got a rugby player or a footballer with an offended ankle, that kind of 10 milligrams of morphine, if they're 100 kilos, is kind of going to be your initial dose. And so give confident doses of analgesia. Obviously, you want to be careful with things, but kind of 1 or 2 milligrams is probably not going to touch the sides in that kind of patient. So good confident analgesic doses. And remember things like if Penfrox, if you've got access to that, or Entonox even, you can add a face mask into the Entonox system to make that kind of a really good inhaled analgesic. And you can do a lot on Entonox and morphine and that kind of thing. So again, more than happy to discuss those jobs and come out. But what I'd encourage people to do is give good doses of analgesia first, and don't be afraid of giving kind of proper doses. The guideline dose for morphine is 0.1 milligrams per kilo, and most patients will be getting 7-8 milligrams as initial dose in this day and age, won't they? So please do feel empowered to give good analgesia, because that's one thing that anyone working in the pre-hospital care environment can do, is take away pain and suffering.
Yeah, listen, I agree. And to your point, actually, about the peak effect of morphine, depends which route it's given, but the peak effect of morphine intravenously could be 15 minutes. And so it's prudent to, like you said, if you're going to approach the patient and dose them up to 10 milligrams and or greater, depending just incrementally, but you have to, there has to be a period of waiting to get to peak effect to understand whether the intervention is working. But also to your point around combination therapy. You don't, it doesn't, a pain modality doesn't have to be given in isolation. There could be another approach, a short-term acting Penthrox together with morphine or indeed IV paracetamol, and that synergistic effect can achieve exactly what you want in combination. So to your point, and giving it some time to maybe see the peak effect of a drug. I'm in danger of really. I think we've kind of answered the next question, which is really around this clinical uncertainty on scene, or risk of over triage or under triage. And speaking to the desk, I think to your point is a great way to really just break down the problem set and just demystify any issues and just it's also sometimes when you can maybe chat to someone like yourself and just analyze the patient presentation, you can sometimes answer the questions yourself and just it's that reflection and bouncing it back. So I guess it's that shared decision making. Two heads are better than one, and just getting a semblance from indeed yourself or another critical care paramedic on the desk is, would this be an appropriate dispatch? This is the patient presentation. And I guess in a way, and I'll get you to speak to this, just, over maybe in a way over communication or indeed engagement is never dissuaded because it allows you into that clinical presentation a little bit more. It allows a second brain into that, and it also hopefully narrows any missed dispatches that you could have maybe added value to.
Sure. And I think you'll never, as a, if I think about when I've requested additional help and that kind of thing, you'll never, um, I guess, hopefully, never regret asking that question. But you might regret it if you get to hospital and then you kind of are thinking backwards, or patient then deteriorating, like, oh, why didn't I ask earlier, kind of thing. I think you'll never regret having that conversation. And having that conversation doesn't mean a dispatch, does it? So, it doesn't mean that somebody's coming. It just means you're having a conversation to see if someone is coming. Equally, if you know somebody is needed to come, then just saying, coming up and requesting the team be dispatched and giving a clinical handover would be great. I think we often get stood down quite quickly from jobs as well and then called back later on. And so I'd encourage, if there is a team coming, for people to kind of really do that good clinical assessment and then provide that information so that the team can make a decision on standing down or continuing. Because I guess don't stress in those initial phases about taking the team up if there's somewhere else they can be, because we'll always divert teams and send people around. So just provide all the information that you can on that patient back to the desk so that the decision can be made about resourcing. So yeah, don't stress about it. And I think the other thing is, like, a really key part of a job cycle, I think, is that debrief afterwards. And so when you've had a team come out, just have a debrief with them afterwards. And that should be a two-way debrief. Everyone should feel empowered to feed back to the team on how they were in terms of interactions and that kind of thing. Like, we want to know if we come across abrupt or rude or something like that, because people, I can promise you that critical care paramedics don't mean to come across like that. But if they do, then they need to know, otherwise they can't change it. So providing feedback is really key. And then asking questions. And if you don't want to ask in person at the time, then most of us will always be happy to have an email a couple of days later or whatever and have a chat about that patient. So yeah, I think debrief between the teams at the end of each job is key. And if that's not possible because of logistics, or someone if you fly a patient into hospital and you don't get that chance, then trying to follow up through email afterwards is always good. But yeah, please call and have that conversation. It'll just kind of make you feel better about your decision making, and allows kind of the best care for the patient if required. And do speak up in debriefs and on scene as well. There's been plenty of times where I've been saved in a checklist environment by student or somebody saying, "Oh, usually I've seen this happen." You go, "That's very true. Thanks for that." So yeah, we are all kind of working as one team, aren't we? Um, so the more conversation and interactions we can have, the better.
Yeah, fantastic. Absolutely. Absolutely. So, Callum, just pivoting slightly, and this is a phrase I never really used to use, but there was an inference actually around an optimization, like a HEMS ready patient on scene before you arrive. Could it get you to, although that wasn't a phrase, the expectation or indeed that maybe the desire was that they would have skin to scoop, so they'd just be you'd be able to, like you say, before the HEMS team got there, there would be a full assessment and that's visualization and palpation of the mechanism or indeed the energy transfer at the actual anatomy, but also two large bore cannulas if that was possible, oxygen at 15 liters a minute with the reservoir bag filling, and indeed, yeah, a 360 access to the patient. Could I get you to kind of speak to that and maybe expand on that for what you are looking for that critical care patient before you arrive?
Sure. I think all of those things, if they're able to be achieved, is fantastic. So we still would love that kind of stuff. It's obviously difficult depending on whether you've got a medical patient or a trauma patient. If you're trapped upstairs and looking to extricate and all of those kind of things makes it difficult. And remember that, the critical care paramedics that are coming out to you have all been in that same situation. And so if you're still stuck upstairs, we've all been there. So we're not going to be annoyed that you haven't managed to get the patient out or anything. We fully get it. Um, but yeah, those kind of really optimal things, I think, start with a really good handover. And I always kind of write my handovers down if there's another team coming, or if before I get to hospital. So a really good handover is key, and try and do that at the patient if possible. Often we're kind of met as we're walking towards scene by somebody who starts giving a handover, and that's great and fine. But the first thing we want to do is just lay eyes on that patient so we kind of know where we're going down. So just meet us at the kind of foot of the patient, I think, is the key thing. Then we can have that conversation. And it also allows then if you have any initial issues, so if you've got a real airway problem, you can say, we've got an airway problem. Someone mind going to that, and one of our team will go and sort that out whilst the rest of the handover takes place, kind of thing. So that's kind of quite key. Yeah, extrication or or having the patient on the stretcher if they're outside, those kind of things are really great. 360 access, gaining access, 2 points of access is always good. We're always going to want to because they do tissue, don't they? And they do fail, so we always want that backup, and that can be IV or IO. So if you're struggling for IV and the patient's really sick, then moving to IO is completely the reasonable thing to do in that situation. Um, yeah, well oxygenated. So if you're having to ventilate them, just aiming for that kind of normal end tidal CO2 and probably towards the lower end of normal end tidal CO2, just because we know that that kind of there's a gap in sick patients between that end tidal and the arterial CO2. So aiming for that normal oxygenation levels, getting them well oxygenated, because especially if we are going to go into an anesthetic environment, we want them pre-oxygenated really well. Um, And I think the other key thing as well is getting as part of the handover and thing is a kind of trend. Because if you've been there for 15 minutes and the patient, despite your intervention, is continuing to deteriorate, that means we're kind of need to really push hard to get things done quickly. Whereas if they're actually on an upward trajectory, even if they're still really sick, that means we might have a couple of more minutes to optimize things, but before we move into any big interventions. Um, so I think, yeah, those kind of things, having suction available, a couple of points of access, fluids if they need them, and again, if you've got a trauma patient who's hypotensive and has no radial pulse, a small amount of saline is what that patient needs in the time if you don't have access to blood products. So, try and optimize that physiology before we arrive. Is the kind of key thing, I guess. And yeah, starting that extrication process because we all know that no matter how hard we try, that 5 minute extrication is going to be 10 minutes or 15 minutes, just given the environment that we work in. And I think the other thing is warm, keeping the patients warm. So blankets and getting them in a good airway position, those kind of things, keeping them comfortable, good analgesia as required, that kind of thing. Um, are the overarching things, and I think we'll kind of talk a little bit later about the exact kind of interventions that we'd like to have done before we arrive, if at all possible.
Yeah, indeed. No, indeed. And actually, let's go there because I'll just roll two questions into one, really, because they're kind of similar questions. And that really would be around optimization of a patient for fear. So, pre-hospital emergency anesthesia, including positioning, access, monitoring, and adjuncts to shave time off. And that rolls into kind of what can be done within the first 10 to 15 minutes to really help support an advanced intervention like pre-hospital emergency anesthesia. So I guess that's the question. But just to your point and just coming to land on what you were saying, it's even simple things like making sure the blood pressure cuff is on the arm, in the, not over close, but also, if there's a turbo cuff option or a rapid reinflation option, just simple things like just trying to cleave as much information, to your point, from the monitor to innovate for a trend. To understand, like you said, where you are with the patient, where the patient's going, are they going downhill or are they improving? And actually, yeah, getting as much information as quickly as possible back from that patient, so you can kind of just make the best informed decision. And something which I learned from London HEMS, which is a really interesting point, is it's almost, just pointing the ambulance in the right direction, so that actually when you load a patient, you can move away from scene in the right direction. You can shave minutes off by not having to do a 3 point turn or something like that, and also being mindful of the handbrake on and handbrake off time. When you're really when you start to really drill into, the on-scene time. What time did I pull that handbrake up as the driver of that ambulance or the driver of that critical care asset, if it was a ground-based asset, versus pushing it down and driving off to hospital? Are you truly cognizant of shaving those minutes off? And it's just these, to your point, there's incremental gains of time, of logistics, of simple things like the blood pressure cuff being on the right way, auto cuff and just starting to really cleave these 1% from the scene. Could I get you to sort of maybe expand on that?
Yeah, absolutely. I think they are really kind of key things that everyone can do, can't they? And I think that that ambulance pointing in the right direction one is definitely one, especially if you're on like a big scene with other emergency services, making sure you're not blocked in by police or fire or other vehicles. And if you are a second arriving resource or something, that your parking allows the first resource out and all those kind of things. And they're things that um, we often forget about, aren't they, in the heat of the moment? But like you say, they really do make a big difference in terms of time, and we are looking for those kind of marginal gains, aren't we? Um, yeah, so managing the scene is absolutely key. Yeah, early 360 access, because the more you add on to the patient as time goes on, the harder it is to get your access and that kind of thing. So I think in the first kind of 10, 15 minutes, think about how you're parking. I always have in the back of my mind as I'm walking into a scene, I'm kind of figuring out how I'm getting out of that scene. So, if there's a couple of flights of stairs, you might need to call fire or heart teams, etc., early to help with that extrication rather than getting to the point of extrication and then needing them, that kind of stuff. So just always having a mind on how you're getting out of the situation that you're in. Um, Good early primary survey, because that's going to give you the key kind of things of, do I need HEMS or critical care? Is this a discussion or is this patient kind of okay? So good early full head to toe assessment. I think if you've got a trauma patient, you want to imagine you've got paint on your gloves, and you want to kind of make sure that there's paint in kind of all the key areas of the body systems for that patient to make sure you've not missed anything. Just constantly running A to E in your head, I think. Constant A to E to make sure nothing's changing. Like you say, when you put that monitoring on, no number in isolation is overly helpful. So having all of those numbers together, and like you say, kind of the trend is more important. So if you've got that blood pressure on the turbo or the 2 minute cycle kind of thing, then you've got 10, 15 blood pressures to tell you on if we're trending in the right direction or the wrong direction, that kind of thing. And a constantly wearing blood pressure with no numbers is a bad thing, hey. So you've kind of got that in the back of your mind. As we said, keep them warm. Obviously, you don't need to actively warm patients who are kind of post-ROSC or anything like that, but just protecting them from the elements so they don't become hypothermic is key, and really aggressive warming in our trauma patients where possible. And create that space and room, and really look at extrication early in these really sick patients. And that may be going back to basics, right? There is nothing wrong with the good old carry chair down the stairs in many situations. Um, in terms of kind of setting up for a FIA, we know that kind of NICE give us in their guidance kind of a 45-minute target from time of injury in trauma patients. That's really hard to hit in the current day and age. And so any kind of time saving is key. The good news is that apart from setting up the kind of kit dump, drawing up the drugs, and actually providing the anaesthetic and the intubation, there's nothing that can't be done by by a paramedic before the HEMS team arrive. So the things that we'll always need are 2 points of IV or IO access, a suction set up with a Yanker sucker connected and ready to go, know that it's working. Oxygen, patient being oxygenated, and we'll always usually use apneic oxygenation as well. So adding in kind of nasal cannulae to the circuit for that patient, or giving oxygen if you've got end-tidal CO2 on, and that kind of thing as well. Patient off the floor, we very rarely anaesthetize patients on the floor, so if you can get them up onto the stretcher, that kind of thing. We'd normally need kind of at least two, but preferably three oxygen bottles as well, because we'll have the kind of apneic oxygenation, the actual bag valve mask or whatever's being used for pre-oxygenation, and then usually one connected to the ventilator ready to go as well. So kind of quite heavy on the oxygen requirements. Um, and then the big thing, is that we've moved away from rushing in to intubate patients quickly, and we really try and optimize the patient before intubation. And so optimizing that patient, having a bag of fluids set up to flush drugs, but also optimize their blood pressure. If it's a post-ROSC situation, using your post-ROSC adrenaline as required, and that kind of thing, making sure the patient's well oxygenated. They're in a good airway position. Everyone can put someone in an ear to sternal notch airway position. I think coming off the scoop stretcher, if possible. A scoop is a horrible place to intubate somebody. So if we can get them off the scoop stretcher, even if it's a trauma patient, quite often you're going to, pelvic bind them and worry about meals and all that kind of thing. But you can still keep them safely on the stretcher without the scoop underneath them. The scoop should be an extrication device, not transport device. So getting them off that and kind of into a good position for us. And then in the back of the truck or outside is fine. What I wouldn't want is kind of people waiting around outside in the elements for a team to arrive. So going into the back of the truck is reasonable. And as we said, if you're ahead of the game, ahead of us getting to you, then we can always set RVs to not have kind of people sitting still and that kind of thing. But I guess my key points would be utilize your capnography because that will tell you how well the patients are ventilating. Have your monitoring on cycles where possible. A couple of points of access, whether that's IV or IO, suction out oxygen bottles and that kind of thing. And the real key is that kind of extrication picture, because the quicker we can manage that extrication, the better. And I think it's safe to say that the evidence from is in road traffic collisions, obviously at the moment in terms of extrication and rapid extrication being the key thing. But in all situations, whether that's from a house down a ditch, wherever it is, managing those patients in those situations are not great. So getting them out as quick as possible is really key, and just constantly reassessing that A to E and kind of fixing anything that pops up, I guess.
Yeah, indeed. And all that makes sense actually. And is fantastic advice to instigate, like you said, ahead of time. Something you speak to there, Callum, is which is really interesting is this just principle of redundancy. And it's very much the similar principle within aviation. It's just having secondary redundant systems. So a redundant suction unit or redundant secondary oxygen, a redundant IV line, just so that you actually just there's no single point failure within the system, so that if one part fails, you've got the ability and indeed the leverage to lean on a second IV line or a second oxygen bottle or indeed a second suction unit. Um, and that principle of redundancy kind of really echoes through any halo procedures where they are high acuity, high risk, and you want that sense of that safety mechanism really of having redundancy in the system to allow and part of the redundancy in the system is also to your point having a team. It starts way before the second IV line. It starts by contacting the desk, and it's two heads are better than one. So part of the redundancy is saying, well, have you checked this or have you done that? Maybe consider this, and it's both ways. But also to your point, allowing the team to speak into your practice, and that's a redundancy in itself. Allowing the most junior person to say, actually, Callum, that second suction unit isn't charged or isn't working, or there's no oxygen in that second bottle. Allow just and having these multiple points whereby you are giving yourself leverage and mitigating error. But could I get you to speak to maybe any common errors that you do see, or any indeed common oversights that you see when you're landing in a helicopter, and there is maybe things which could have been done slightly differently on scene, Callum.
I think it is just about kind of remembering those redundancy things. So I think often there is just the one point of access, and I've accidentally pulled out my own cannulas more times than I care to admit, kind of thing. So just thinking about having that the redundancy, I think as well that kind of point around trends of care often the monitor, you press the blood pressure and it just gives you that one blood pressure, doesn't it? And sometimes we can arrive to just kind of see the last blood pressure was 15, 20 minutes ago, kind of thing. So just having that prompt in the back of your mind that if this is a sick patient, just adding that blood pressure onto cycle as an example, and thinking about that extrication, kind of always trying to have that momentum. I think sometimes we get stuck where the patient's physiology maybe isn't perfect, and we're a bit worried that when we move them, they might deteriorate further. Um, but the patient's blood pressure, if we're not actively kind of treating it as such, is always going to continue to deteriorate if we just sit still upstairs, kind of thing. So sometimes there is an uncomfortable decision that a recognition that this patient may have to deteriorate, may deteriorate on extrication, but we have to do that to get to the end goal. And again, that's where that shared decision making can happen, and where you can kind of be, I guess, have the encouragement from the desk to go through with that and just and push through that extrication thing. So I think, yeah, the kind of the full monitoring, the kind of single access and the kind of delayed extrication, I think, are where things where often we kind of get stuck in a kind of cycle. And I'd encourage people to kind of just push through those situations where possible.
So let's talk about pre-alerting. Could I get you to speak to really maybe some of the most powerful and useful reflections really on pre-alerting and communication before you get to hand the patient over at hospital? One of my revelations was really just that on scene, I didn't actually have to wait till I was in the vehicle to pass a pre-alert, especially if you were close within London. I could actually pass a pre-alert whilst I'm still in the house or still on scene, not even in the ambulance. If we were so close, I can afford that 10 minutes doesn't have to be me sitting in the front of a vehicle waiting it can occur in different situations and environments depending on that 10-minute window. And I guess the question back to you really would be Is there, should crews wait maybe before pressing a pre-alert for an hour or an hour and a half, or indeed 50 minutes? What's the optimum time for a pre-alert to get that team ready to the bedside?
In terms of getting a pre-hospital team to come to you, I think as early as possible. I would probably say kind of I'd give it from when you get on scene kind of 5, 10 minutes. If if it's an immediate request, then that's fine. But if it's a discussion or a stand down or anything, just give it 5, 10 minutes to kind of um, get that key clinical information. Write it down if you have the chance to do so, because it'll always you'll always get muddled when someone arrives or when you're on the radio or that kind of thing. Um, I think in terms of pre-alerting to hospitals and that kind of thing, I agree. You don't have to wait until you're moving or anything like that. Get them in early, 10, 15 minutes out. Remembering that kind of time to hospital, we kind of arrive at hospital, don't we, and take a sigh of relief and our kind of game's over as such. But that's not the end for the patient. And actually, it takes time for the hospital to book the patient in, to do their assessment on the patient. And so actually just getting the patient to your hospital doesn't mean that they will get that anesthetic, that blood products, the whatever it is that's required. And so sometimes it can be worth starting things earlier in the pre-hospital phase just to smooth that transition through. Um, so yeah, I think a good clinical assessment to be able to provide a good kind of A to E of what's happening with the patient and those kind of observations. If you're looking at things like GCS, motor score is a key one on a GCS and that kind of thing. Um, and just have a structure that works for you so that you can get that kind of key information across to people, I think. Um, but yeah, certainly I guess I certainly wouldn't rush into kind of providing the information if I didn't have it all. Unless that is I've arrived to this patient and it wasn't given as cardiac arrest, but it is cardiac arrest, or I need a team because I've walked into a patient whose airway is clearly compromised, kind of thing. But yeah, take your time, take a breath, and just think about what you want to get across before you kind of say it as such.
Yeah, indeed, indeed. Just finally, as we're coming to land, actually, Callum, if there was a mental checklist that a crew could have in their mind, just to, I guess, in a way, get a patient ready for Great Western Air Ambulance Charity, or indeed any critical care team, what would the preferable sort of mental checklist look like?
I think just A to E, knowing you've had that A to E, that you know what's happening with your patient, knowing that the patient's optimized, and if anything has is changing, that you're on top of that. And then that you've got those things like the kind of 2 points of access, you've done as much extrication as you possibly can, kind of thing. That would be my best way to do it. And we kind of have A to D checklist for crews that we kind of utilize for them and hand out and that kind of thing. And that is kind of airway, breathing, circulation, disability, like which hopefully is familiar to everyone. So airway, good airway position, got some suction, using adjuncts as required, and managing that patient's airway. Breathing, I've got enough oxygen, got a couple of cylinders, I've optimized their ventilation utilizing CO2 and SpO2, and I've got nasal oxygen on as required. C, 2 points of access. Got a bag of fluids up for flushing and trying to normalize their blood pressure as best as possible, depending on the situation that I'm in. And then D, extrication, blankets for warmth and airway position, and also that kind of pesky blood glucose. Remembering to get that in the kind of altered conscious patients because you don't want to go down the kind of RSI bandwagon and then find out they were just hypoglycemic. So yeah, good patient assessment. Follow that A to E kind of through, and early information um, is key. And I think just to kind of leave people with, like, just be confident in your own ability. The level of care that paramedics and technicians, ECAs, whatever that level is that you're working at, that we see provided on a day-to-day basis across the UK and back in Australia and that kind of thing, pre-hospitally now is amazing. So be confident in your own ability because you're all very good clinicians out there, and just remember to keep the patient at the forefront of your mind.
Listen, that's fantastic. And that's a great way to finish off. Listen, thanks, Callum. It's always a pleasure to have you on the podcast. And indeed, yeah, just get your received wisdom and your reflections. Thank you so much.
Thanks very much for having me, and yeah, if anyone wants to get in contact, more than happy to chat through or help out where I can. So thanks very much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.